threat for the pulp health. And the enamel and dentin are a mechanical barrier against invasion. Something is wrong maybe with this program because I can't move my mouse. Here I can't see any mark. Just a moment, or maybe here. I don't know why I can't see. Maybe I will show you in this window. Okay. So in the oral cavity, microorganisms in the oral cavity are the constant threat for the pulp health. Because at first, if there are favorable conditions for activity of carcinogenic bacteria, when we have carbohydrates intake, bacteria may use them as for their metabolism. When oral hygiene is maybe not proper, so then caries disease may start. If enamel and dentin are sound, so they are a mechanical barrier against invasion. But if caries disease starts in our oral cavities, so then we have pathway from the microbes through the hard tooth tissues, and so penetration of microorganisms through the enamel and dentin may lead after some time, if it is not treated, to inflammatory reaction from the pulp. And direct exposure of the pulp to microorganisms creates necrotic. At first we have inflammation, but if it is not treated, so then inflamed areas become necrotic zones inside the pulp, and it moves here inside the pulp, and it moves toward the apical area, toward the apex. If the majority of pulp becomes necrotic, so then inflammation, then necrosis moves beyond the apical constriction, and it leads to a periapical tissue inflammation. Slide. What is the purpose of endodontic treatment? So the purpose of endodontic treatment, it is protection of tooth and periradical tissues against disease progress. If we talk about the diseases and protection barriers within the tooth, so we have 3 stages of protection. When carcinogenic bacteria attack the hard tooth tissues, so we may have exposed dentin, and we should protect exposed dentin from penetrating microorganisms inside toward the pulp. So it is our first stage. If microorganisms penetrate dentin, so then we should protect the pulp that may be exposed after some time. And after invasion into the pulp, so we should protect periapical tissue. So here you have these 3 barriers, starting from the hard tissues of the tooth, and then soft tissue, pulp, and then periapical tissues. We should, if we want to stop the pathologic processes, stop and protect spreading of the infection into the whole body, into our whole organisms. So this first step, exposed dentin protection. And so in caries cavities and non-caries cavities, bacteria may penetrate the dentin tubules, and metabolic and disintegration products have cytotoxic effect on the pulp. So if we have exposed dentin, how can we protect it? We can cap exposed dentin with a proper specimen. In this way, we can isolate the dentin from the influence of caries cavity and the oral cavity environment. And capping exposed dentin also protects the dentin from the progress of pathological process. So we can stop this pathologic process at the level of hard tooth tissues, and we make it impossible to spread this process into the pulp. If the pathologic process is not treated, so then we have exposed pulp. What can we do if we have exposed pulp? So we can also protect it with odontotropic materials in aseptic conditions. In this way, we have a chance to maintain pulp vitality by reparative dentin formation to create dentin bridge. Because if we have exposed pulp, so it means that we have connection between the between the cavity within the tooth and the pulp chamber. Yes, so we want to close this cavity, and we try to create the dentin bridge. And this procedure should be attempted only when a small mechanical exposure of the pulp is present, and this pulp should be otherwise healthy. The tooth must be isolated with a rubber dam, and we can perform it providing that adequate hemostasis is achieved. Also, this early application of odontotropic materials on exposed pulp gives a chance to retreat the initial pulp inflammation. And in this way, after doing it, pulp can act its physiological functions. So we can, performing direct pulp capping, you can still maintain the pulp inside the pulp chamber and inside the root canal space. Our third protection in barrier, it is protection of periapical tissues. We should remember that irreversible pathological changes of the pulp are the threat for periapical tissues. So, if we remove inflamed or necrotic pulp, if we prepare the canal in a chemical and mechanical way, so chemical using irrigants, mechanical using endodontic instruments, and after this preparation and disinfection of the root canal, we tightly obturate the root canal space. So in this way, we obtain a closure of the entrance of infection from the oral cavity through the tooth cavity to the tissues, to the periapical tissue. There should be this to the periapical tissues. And here you have some examples. Here you have tooth 407 on preoperative radiograph. So here we have unusual area caries with a shadow that suggests also occlusal caries. And this tooth was sensitive to cold stimuli but didn't hurt spontaneously. A radiograph like this suggests that there is a high risk of pulpar exposure during preparation of a cavity. And here you can see that caries was removed till the close proximity of the pulp, but we don't have pulp exposure. X-ray taken before is some help here, as it gives an idea where the pulp front is in relation to the caries cavity. But the radiograph is so it is helpful, but it doesn't indicate the proper the exact maybe extent of this cavity, because usually it shows something smaller than it is in reality. Yeah, so each time we have something close to the cavity, a shadow visible on the X-ray that is close to the pulp chamber. So in reality, it may turn out that it is inside the pulp chamber. And here, after preparation, after cleaning the cavity, the line is placed that covered. It is a temporary restoration then placed like GIC or resin modified GI. So retaining for more caries removal is called stepwise technique, as the caries is removed in 2 steps separated by a couple of months. Here on next visit, this temporary material was removed because we wanted to give the dentin chance for becoming more hard. So after this time, temporary material is removed, and we check whether it is more hard on the bottom. Yes. And final excavation was performed. If dentin on the bottom is hard, so we removed last layer of caries. After removal, new lining was placed here, and it stimulates further tertiary dentin formation. This first layer of lining is covered then with resin-modified glass ionomer, and everything is then restored with final restoration. So it was example of indirect pulp capping when we didn't have exposure of the pulp. And here we have maybe another example of exposed dentin protection. After removal of caries tissue, we can see on the bottom a pulp exposure. Please look here, it is visible in this area. Here calcium hydroxide was placed for direct pulp capping. Here resin modified GI, etching procedure, and then we check after etching whether we have properly etched enamel and dentin. So here frosted appearance of hard tissues, and here restoration placed. Yeah, so it's necessary when we perform direct pulp capping. It's necessary to to have follow-ups regularly to ensure that the tooth is vital. So the key factor in pulpal healing after exposure is absence of infection. Okay, so we had maybe these two examples of tooth protection, exposed dentin and exposed pulp. So as I told you, in periradicular tissues protection, these irreversible diseases of the pulp are a threat to periapical tissues, and when we remove inflammatory or necrotic pulp, when we clean and shape properly root canal system, obturate it properly, so then we close the way of the infection to the periradicular tissues. Yes, what is the aim of pulp capping? Yes, because we told about pulp exposure and pulp capping. So if we cap the pulp, so we can maintain pulp vitality as a first barrier protecting the organism from the infection from the oral cavity. The aim of periradicular tissues protection, so it is similar to maintain as it comes to spreading infection. But we have to remove the pulp at first because it is the source of infection. When we perform endodontic treatment, so we should remember that at the maybe so this a picture from Ingles endodontic. So here at the apical constriction area here we have so-called mixed tissue. So it is slightly pulpal, slightly periodontal tissue, and it is very important to leave this tissue here at this point because if we leave it intact, so it closes this area after pulp removal. And if this tissue is not hurt, if it is not damaged, so then we don't have possibility of spreading infection from the pulp into the periapical tissues. So to maintain vitality of combination of pulp and periodontium tissues as a second organism protective barrier, after the extraction of this barrier, tooth is a potential site pocket of infection. So we should remember that when we perform endodontic treatment, so that we shouldn't work deeper than established working length, because you remember that working length is to the apical constriction, yes, this narrowest point inside the canal. And we shouldn't put the instruments deeper because we can spread infective tissues beyond the apex. We will damage this mixed tissue here, and we can open space for spreading infection from the root canal to the body. And if we don't treat irreversible pulp diseases, so we will have complications of periradicular tissues. And effective root canal treatment sometimes needs implementation of antibiotic therapy or surgical procedures. What is also important if we perform endodontic treatment, as it comes to this biological aspect, yes, because I still tell you about maybe this protective barrier that shouldn't be damaged if we want to not to spread infection from the oral cavity to our whole body. So if we perform endodontic treatment, so our therapy of choice should be pulp extirpation in local anesthesia. Because it is a biological method of treatment in relation to periradicular tissues, because this undamaged mixed tissue undergoes mineralization and can block periapical area from pathogens. So nowadays it is not advocated to perform pulp devitalization. Devitalization means that we place the medicament that may make the pulp dead. And after 2 weeks, we can make another appointment with the patient. But within this time, when the pulp becomes devitalized, it can damage also this mixed tissue. And it leads to loss of metaplastic properties of this tissue, that it can't become mineralized and can't close this area. So absence of hard tissue barrier make it possible to penetrate the microbes from the oral cavity, from the root canal space into periradical tissues. So if we perform pulp devitalization, we have a lack of mechanical barrier protecting periradicular tissues against infection. So as I told you, when you prepare the root canal, so we shouldn't pass the instruments beyond the established working length, so beyond this physiological apical constriction. Please remember, in this way, we prepare the root canal properly, and this mixed tissue, pulpoperiodontal tissue, is protected. Yes, so our principles of proper preparation of the root canal. Preparation of the root canal to the apical constriction, both in teeth with vital and necrotic pulp. Above the apical constriction, so there is mixed pulpoperiodontal tissue which remains alive even in the presence of periapical changes, lesions. Passing the instruments and filling the canal beyond the apical constriction destroys the pulpoperiodontal tissue. In infected canals, the infection is pushed into the periapical tissues, which leads to inflammation or exacerbation of chronic inflammation after the visit, and clinical symptoms usually occur in the form of pain, swelling, temperature, which indicates that the infection has passed to the periapical tissues. And teeth with necrotic pulp should be always treated as teeth with infection within the canal, regardless of whether there are changes in the periapical areas or not. Now, maybe it is this statement is maybe not properly understandable by you because you started maybe with this only pulp diseases, but next week or maybe in 2 weeks' time, we will have also this periapical tissue inflammation symptoms, diagnosis, so it will be more familiar for you. So teeth with vital pulp means that it may be sound pulp, but it may be also inflamed pulp. You know from a previous lecture that we have reversible and irreversible pulp inflammation. Yeah, so reversible means that it is not necessary to perform endodontic treatment. It may be reversed after proper preparation of the caries cavity, or when we perform indirect or direct pulp capping. If we have irreversible pulp inflammation, so then we have to remove the pulp from the root canals. So it is inflamed and still vital tissue, but inflamed. As I told you on this first picture, just a moment, it is slide 31. here on this picture. Yes, so at first we have a cavity, then inflammation of the pulp, and here direct pulp exposure to microorganisms leads to necrosis zone in the pulp. If we have this necrosis, if this process lasts longer, so then this necrosis is spreading toward the apex. We have more pulp affected with necrosis. Yeah? So when the whole pulp is necrotic, so we have so-called dead tooth, not alive tooth. And here, just a moment. Teeth with dead necrotic pulp are always treated as teeth with infection within the canal, regardless of whether there are changes in the periapical area or not. And necrotic masses from the canal should be removed in their entirety. At the first visit, the canal should be prepared mechanically and chemically and tightly properly filled. If we have exudation that persists after complete preparation, so multi-visit treatment should be performed and the tooth should be tightly closed. We do not have leave the tooth open. Yes, if we perform endodontic treatment, so there are only some exceptions when we are allowed for leaving the tooth open. Each time we perform endodontic treatment, when we start the pulp removal, disinfection of the canal, we should close the tooth, because if we leave it open, so then microbes present in the oral cavity can enter again the root canal space. So we shouldn't allow bacteria from the oral cavity to enter the prepared canal because they will find excellent conditions for development inside, and it will be more difficult for us again to eliminate this bacteria from the root canal. So it's necessary to use more potent, more antimicrobial, with more antimicrobial activity irrigants. The most important procedure in the treatment of periapical inflammation in both acute and chronic cases is removal of necrotic masses and all irritants from the canal and its proper feeding. Yes, so we should still remember what is the cause of infection. If we have irreversible pulp inflammation, about this irreversibility states presence of spontaneous pain. Yes? So if patient comes to the dental office and tells that his or her tooth is painful, so we should ask when it is painful, whether it is connected with a stimulus or not. If pain is stimulated by, for example, something sweet, cold, or hot, and it disappears quickly, so it means it is not connected with the pulp disease. But if the stimulus if this pain is prolonged, if this pain is present after removal of the stimulus, or if the patient has spontaneous pain, so it means that the pulp may be inflamed in irreversible way. So if we have irreversible pulp inflammation, it means we should perform endodontic treatment. We should remove the source of this pain. It means this inflamed pulp. In necrotic pulp, this tooth is painless because the pulp is dead. Till the moment we don't have lesions around the root apex in the periapical tissues, in periradicular tissues. So the tooth may be asymptomatic. It is not painful for the patient, but after some time, it may become discolored, and it may be information about necrosis of the tooth inside. But if microbes spread into periapical tissues, and when lesion in periapical tissues starts, so then we may have inflammation of periapical tissues, and it may cause, if it is in acute state, it may cause pain to the patient. But if we have this if we have this periapical tissues, so it's necessary also to remove the pulp from the root canal because it is the source of infection. So starting from irreversible pulp inflammation, our activities should be removal of the pulp from the root canal. What is also important if we talk about biological aspects of endodontic treatment? All dental procedures performed on the exposed pulp or near the pulp chamber should be done in aseptic conditions. So it means that the best option is our working with in dental dam isolation. Yes, and if we don't have possibility of rubber dam placement, so then we should use cotton rolls in such a way that we protect the tooth from saliva. But the best solution is working in rubber dam. Okay, and here maybe what kind of treatment should be performed. So pulp diseases treatment. When vital pulp is left, when we have still vital pulp in the tooth, so we perform biological treatment. So it is indirect pulp capping, direct pulp capping. It may be also partial or full pulpotomy. When the pulp is removed, so what kind of treatment may be performed? Pulp extirpation in local anesthesia, necrotic pulp extirpation after devitalization, but as I told you, it is not recommended because it may lead to damage of this mixed tissue, pulpo-periodontal tissue, or antiseptic root canal treatment may be performed in case of necrotic pulp inside, but not necrotic after devitalization, but necrotic as a consequence of first irreversible pulp inflammation. Okay, so again, if we have a pulp inside and we want to maintain the vital pulp inside, we may perform indirect pulp capping, direct pulp capping, partial or full pulpotomy. But if we perform pulp removal, so it may be procedures, extirpation, local anesthesia, and generally antiseptic root canal treatment if we have necrotic pulp inside. And now maybe because I will join slightly maybe this biological aspects of the endodontic treatment with this topic about the conservative treatment of pulp diseases, because at first you had this pulp diseases topic. What does it mean, conservative treatment? So it may be seen maybe from two aspects, because it may mean non-surgical treatment, so something that is not connected with micro oral surgery. Just a moment, I will show you. Or conservative treatment, it means that we perform biological treatment, vital pulp therapy. So this biological treatment, vital pulp therapy, so it means that it is something before we start removal of the pulp. But this conservative treatment connected with non-surgical treatment, it is maybe on a later stage when we want to save the tooth from extraction. Yes, because this conservative treatment is focused on maintaining the tooth inside. So this non-surgical treatment, it is at a later stage when we have removal of the pulp from the root canal, but this biological treatment is on earlier stage when we want to save the pulp inside. Yes, so there are two stages of this conservative treatment. But so if we talk about conservative treatment of pulp diseases, so it is rather something that leads to maintaining the pulp inside the pulp chamber. So it is this biological treatment, and it is vital pulp therapy. So vital pulp therapy is indicated whenever the remaining pulp exhibits reversible pulpitis and can be selectively induced to produce a reparative barrier that protects the tissue from microbial challenges. So in particular, direct pulp capping, so it may be at first indirect pulp capping, but it is connected also with direct pulp capping that can be performed for teeth with deep caries, mechanical exposures, and also traumatic injuries to maximize pulpal preservation. And the outcome of treatment for direct pulp capping or pulpotomy will be determined by the initial diagnosis, which includes radiographic evaluation, pulp testing, clinical evaluation, and patient history. Please remember that each time in your work, you shouldn't limit your way of checking the tooth state, making the diagnosis and decision what to do with this tooth. You shouldn't limit to only one examination, one test. Each time, you should use various ways to assess the tooth state. So, for example, you shouldn't rely only on, for example, radiographic evaluation or only on patient relation. So, you should ask the patient what are the patient's feelings, relation, what are the patient experiences, but you should also perform clinical examination. So here is evaluation, so checking what is inside the oral cavity. You can perform, for example, pulp test, but you can also perform additional examinations, for example, radiographic evaluation. And summing up everything, you can put the diagnosis and decide about the proper treatment. So in vital pulp therapy, the intention is to postpone more aggressive therapies that could eventually lower the long-term prognosis for tooth retention and function. And teeth undergoing root canal therapy and placement of post and cross, followed by full coverage or for example, caspal coverage restorations, show lower long-term survival rates than teeth with vital pulps. Yes, so this statement is important for us because it indicates that each time we have possibility of maintaining the pulp inside the pulp chamber and root canals, so it is better for the future life of this tooth inside the oral cavity. We should still remember, have in our mind, that the patient, for example, if the patient who comes to you is, for example, 30 years old, such a person may have, for example, 50 years ahead of him or her. So we should still think that we should do our best to preserve this tooth inside the patient's mouth. So if we have possibility, we should diagnose the patient properly, and if there are information that we can preserve the pulp vitals, so it is better for the patient's dentition. So each time we can preserve the pulp inside the tooth, so we should do everything. So we can perform, for example, direct pulp capping, pulpotomy, and we postpone maybe these worse outcomes of our of our treatment toward the later ages of the patient. Okay, and here I would like to show you maybe such a guide to clinical endodontics created by American Association of Endodontists. So here on this webpage you can find this PDF file, and here I marked you that the scope of endodontics includes but is not limited to diagnosis and management of pulpar and periapical pathosis through the following avenues. And here you have these ways of treatment. It may be non-surgical endodontic treatment, surgical endodontic treatment, here vital pulp therapy, but also management of traumatic injuries, but it is maybe not the subject of our lecture. It will be later discussed. And also restorative dental procedures related to enhancing the outcome of endodontic treatment. And here, I would like you to show what is maybe hidden behind maybe these terms. Vital pulp therapy, so it is indirect pulp capping, direct pulp capping, and pulpotomy. And here, non-surgical endodontics, maybe just a moment here, surgical endodontics. So it is, for example, incision and drainage in case of abscesses, periradicular curettage, root and resection, and root and filling, root retrofilling, but also biopsy, hemisection, root resection. So here you can see these procedures are performed rather by oral surgeon than conservative dentistry and endodontist. And something between vital pulp therapy and the surgical endodontist, it is non-surgical endodontics. And here, please look, vital pulp therapy, indirect pulp capping. And here you can see indications for the treatment. Indirect pulp capping is indicated on permanent teeth with immature apices if the following conditions exist. So here you have with immature, but this procedure may be also performed with mature teeth. Yes, but here tooth has a deep caries lesion that is considered likely to result in pulp exposure during excavation. But what is important, no history of subjected pretreatment symptoms. Pretreatment radiographs should exclude periradicular pathosis. Patient has been fully informed that endodontic treatment may be indicated in the future. Yes, so here, these indications for the treatment. What are the objectives? To prevent adverse clinical signs and symptoms, to obtain radiographic evidence of root development because it is in case of maybe non-mature teeth. Yes, but the procedure, so just in a moment I will show you again. So it is protection of exposed dentine. Direct pulp capping is indicated when mechanical exposure of clinically vital and asymptomatic pulp occurs, when bleeding is controlled at the exposed site, exposure permits for capping material to make direct contact with the vital pulp. Exposure occurs when the tooth is under dental dam isolation, adequate seal of the coronal restoration can be maintained, and patient has been fully informed that the endodontic treatment may be indicated in the future. And also pulpotomy. Okay, I will show you later. And here in permanent teeth, yes. So, but it is no. So it was vital pulp therapy, and now in permanent teeth, non-surgical endodontics. What are the indications for the treatment? Non-surgical endodontics means that we remove the pulp from the pulp chamber and root canal space. So it is recommended in irreversible pulpitis, in necrotic pulp with or without evidence of periradicular disease, or in cracked or fractured teeth. So there are some. And here, okay. And here, pulp extirpation and local anesthesia is also called pulpectomy. But maybe at first, just a moment, I will show you because here it is pulp. Okay. Just a moment. So I can't. Oh, okay. I can. So here, maybe because among these conservative ways of treatment is pulp capping. So now I will tell you about maybe this indirect pulp capping. So as we talked about it, dental pulp capping, it is application of a protective agent to the exposed pulp, direct capping, or application of a protective agent to the remaining thin layer of dentine. So it is indirect capping in order to allow the pulp to recover and maintain its normal vitality and function. And what are the indications for pulp capping? Indications. So generally, young age, good general condition, good health, yes, so it is indication. local indications, so it is Cary's disease, and also some states. So here it is in Latin. Now Latin is maybe not commonly used. We are more focused on English names, English vocabulary, but here it is. There are states of accidental pulp exposure or making the pulp vulnerable. So it is connected with bleeding of the exposed pulp. And here, exposure of the pulp because the Cary's disease was so developed that Cary's tissue was touching to the pulp in the pulp chamber. Also, broken tooth crown after trauma is also indication for capping. So it depends whether it is direct or indirect pulp capping. So it depends on the line of breakage. Also, non-Cary's cavities such as attrition, abrasion, and erosion may be indication for capping. Good oral health, healthy gingiva, and also if the tooth is needed for future dental complex treatment, if it is important tooth in the patient dentition. So it is also, if it is important, so it is also indication for performing capping. What are the contraindications to capping? It is irreversible pulp diseases. Yes, if we have irreversible pulp inflammation, so it is not possible to perform pulp capping. It is necessary to remove the pulp from the root canal, so it is another way of treatment. Also, bad tooth condition may be also contraindication, or if reaction of the pulp is decreased, so it may be connected maybe with extensive necrotic areas inside the pulp, and it is indication for endodontic treatment. If tooth is painful while we perform percussion, so it may be indication, information about the periapical tissue diseases, and maybe, and in this case indicated is endodontic treatment. Advanced resorption of milky teeth of primary dentition, it is also contraindication. Periodontitis and bad general condition of the patient. So some general diseases that may affect the process of healing. What are the requirements for pulp capping materials? Biocompatibility, antibacterial and anti-inflammatory effect, also odontotropic reactions, reparative dentin formation or tertiary dentin formation should be obtained with these materials. Good sealing to dentin, so we shouldn't have micro leakage, and resistance on chemical and mechanical factors. What are the main materials used in pulp capping? Calcium hydroxide, zinc oxide with eugenol cement, bioceramic materials, MTA mineral trioxide aggregate, biodentin, adhesive systems, but it may be sometimes is controversial. There are people, dentists who approve it and also who deny use of adhesive systems for capping. And laser therapy as a stimulation of repairing processes. Here you have examples of calcium hydroxide material, so it may be biopulp in powder that is mixed with water to a creamy consistency, calcipulp in a paste inside the syringe. So this biopulp is a non-hardening material and it's used for direct pulp capping. But for example, here, live care, so it is hardening calcium hydroxide material, and we take the same portion from one tube and the same from the other. We mix to obtain the same, maybe to obtain one color, because one is white, the other is beige. We mix to obtain one color, and then we can apply it on the tooth. So it is rather used for indirect pulp capping. And here calcium C light cured, so this material containing calcium hydroxide should be light cured by the polymerization lamp. Here also this Dickel, so it is similar to this live material into tubes, hardening material. And here maybe schemes when we have indirect pulp capping, here when we have only exposure of dentine. And here what happens inside the pulp, because here we have enamel, here dentine, and here pulp inside the pulp chamber. So here this number 4, so it is deposition of reactionary dentine by primary odontoblast, so this reaction inside the pulp when we have such a injury cavity without no pulp exposure. But with pulp exposure, so here we have deposition of tertiary dentine matrix, but newly differentiated odontoblastoid cells. And here we should, because enamel dentine and this barrier was damaged, and we have open space into the pulp chamber. So after use of odontotropic materials, we want to obtain here a bridge. What is the protocol for indirect pulp capping procedures? So at first isolation, then preparation. We should prepare the tooth for the final restoration, leaving the mineralized dentine only in the area immediately adjacent to the pulp. And the dentine should be dry, fibrous, demineralized, and give some moderate resistance to gentle scraping with a spoon excavator probe. So maybe this description is maybe in these older books. Nowadays, I will tell you just in a moment what are the recommendations for non-selective and selective tissue removal. And we should place calcium hydroxide liner or maybe other material used in indirect pulp capping. We should place this calcium hydroxide over the here demineralized dentine. If the additional sealing is indicated, a glass ionomer liner should be placed. And then we can place zinc oxide eugenol cement as temporary filling material, but also there may be used any temporary material for a longer time. It may be GICS, maybe a more long-lasting material. And after this 2-3 months period, we should arrange next visit of the patient. Here, maybe mixing cement on a plate, and here skin. So here, caries, deep caries. Here, preparation, removal of the caries tissues. And here maybe some caries tissue is left below to become more hard within this period when calcium hydroxide material is placed. Okay, and here indirect pulp capping in premolar. So you can see preparation. So here caries tissue is still visible. Here it is more clean. And here indirect capping, so calcium hydroxide material placed in this area where we have still a bit demineralized dentine. And here cover with second layer of cementum, and here final restoration. Here, secondary caries, cavity preparation. We don't have here pulp exposure. Here, etching procedure, and final restoration. And direct and indirect pulp capping is described in Fundamentals of Operative Dentistry on pages 108-117. Just a moment, and I will show now maybe about direct pulp capping. Okay, so this direct pulp capping is a process of placing a specialized agent in contact with the pulp with the intention to promote healing of the pulp. The basic idea of direct capping is to generate a dentin bridge composed of secondary or reparative dentin. In an exposed pulp, it should be decided whether endodontic treatment is indicated or the pulp vitality should be saved. So if the treatment of choice is to save the pulp vital, a procedure is called direct pulp capping. And pulp should be healthy and uninfected if you want to save it and to maintain it inside the pulp chamber. So what are the indications for direct pulp capping? So placement of the agent directly on the exposed pulp should be only in the following cases. So it is accidental pulp exposure when excavating deep caries, when we have traumatic fracture of tooth, in case of iatrogenic exposure during cavity preparation. So for example, you prepare a cavity and the cavity is almost clean, but unexpectedly, for example, the patient moves on the jaw and the burr is touching to the pulpal wall and you expose the pulp. And also iatrogenic exposure during crown preparation in the similar way. But as it was here, pulp should be healthy and uninfected in these cases, because if we have infected pulp, if we have any symptoms about symptoms indicating that we have irreversible pulp inflammation, we shouldn't perform direct pulp capping. So what is the characteristics of the exposure? So if we talk about this exposure that may be treated with direct pulp capping, so it should be very small, pinpoint in size, not more than half of the millimeter. What so small area, and we shouldn't also have hemorrhage, or if some blood is visible, so it should stop within 1-2 minutes. It should be possible to control. If this bleeding is not controlled, if it is still present, if it lasts 5 or more minutes, so we shouldn't perform direct pulp capping. And dentin at the periphery of this exposure is reparable, so it should be verified by tactile and visual tests. And exposure site is not a constricted area in pulp chamber or root canal system. The field of operation is completely aseptic, so after exposure, the tooth should be isolated immediately to prevent contamination. Or if you treat this tooth in rubber dam isolation and it happens that there is pulp exposure, so it is better prognosis for maintaining the pulp vitality if you perform direct pulp capping in this case, because this tooth was protected from the ingress of microbes present in the oral cavity. What is the technique for direct pulp capping? So all undermined enamel and unsound dentin should be removed. The cavity floor, the bottom of the cavity and exposure sites should be washed and irrigated with sterile water and dried with sterile cotton. Calcium hydroxide can be used, so it is recommended, or it is also MTA recommended nowadays, or biodentin as capping material depending on the health of pulpodentinal organ and location of exposure site. Glass ionomer as a temporary restoration should be placed, and this gives the dentist time to see whether the pulp is going to heal. Another treatment involves the placement of calcium hydroxide liner and glass ionomer cement as a base, and then a permanent restoration should be placed. So, depending on the situation, it may be a two-visit procedure, or maybe it may be, so if we want to observe the tooth and place final restoration after, for example, 2-3 weeks, or if there were no symptoms from the pulp, we are sure that it was accidental so we can place final restoration, then the cavity is tightly sealed. The patient should be informed of possible signs and symptoms of pulpal degeneration because it means that it's necessary to perform endodontic treatment. So the patient should be informed about the possibility of endodontic treatment in the future if the signs of pulp degeneration may be present. Patient is recalled after 6-8 weeks to evaluate the condition of the pulp dentinal organ and test clinical test and control X-ray. And here, in case of pulp exposure, we can perform direct pulp capping with calcium hydroxide technique. So it's necessary to obtain hemostasis. So no bleeding should be present when we want to apply the material. We should disinfect the cavity, place calcium hydroxide or another recommended material. In this case, for example, MTA or Biodentin. Calcium hydroxide, this covering material, should be covered with resin-modified GI, and final restoration should be placed. If we use this bonding system, so also hemostasis, disinfection of a cavity, and then etching, primer, adhesive resin, resin-modified GI, and composite as a final restoration. Here, direct pulp capping. So in this premolar, you can see after preparation, we have this exposure site. So if it is not bleeding, that you have to remove the blood. If it is only in this area and the bleeding is stopped, so you obtain hemostasis. And if you can wash it with saline, but it is also recommended to use. You can use chlorhexidine or sodium hypochlorite, and then dry everything with sterile cotton pellet, and then you can apply here odontotropic material, and here with calcium hydroxide liner. If we have, so when the pulp of young teeth have been exposed by dentinal caries, so pulpotomy is indicated. Or if the tooth was, for example, after dental trauma, exposed for a longer time, and we have some doubts whether the pulp is infected or not, so then pulpotomy is recommended to be performed. And then pulpotomy may be partial or complete. Partial means that you remove maybe some part, 1-2 millimeters of the pulp from the pulp chamber. Full pulpotomy means that you remove the whole pulp from the pulp chamber, and you place calcium hydroxide or Biodentin MTA on the pulp that was left after pulpotomy. So pulpotomy is good to be performed in younger teeth because pulp in younger patients have regenerative properties. And here you have, for example, injury to the teeth, and you can see after breaking hard tooth tissues, some points of exposed pulp is visible. Here, after obtaining hemostasis, it's possible to place here. So in this case, MTA or Biodentin is recommended. And here the same picture. Okay, what is the prognosis? In indirect pulp capping is generally good prognosis. In direct pulp capping, if it is performed in aseptic conditions, so good prognosis is in 90% of cases. In pulpotomy, so there are worse prognosis because only in 40 cases we have good prognosis, but there are common complications in case of, so in the form of resorption of root canal wall, a chronic pulp disease. Here you can see MTA, mineral trioxide aggregate. So it is material used widely in endodontics for lixification, perforation repair, but it is also used for indirect and direct pulp capping. So here, please look, it is especially indicated for perforation of root, forcation, external and internal communicative resorption, reverse root filling, but also direct pulp capping and also in pulpotomy. What are the main benefits? MTA induces the formation of mineralized tissue through the release of calcium ions, providing the biological sealing of perforations and the total repair of injured periapical tissues, but also it can create dentinal breach in case of pulp exposure. It may be used in humid environment without loss of properties. What's more, it needs wetness for becoming hard. So even if we have some maybe blood on the bottom of our cavity, so it is not an obstacle for MTA to become hard. It helps in setting MTA. Antibacterial properties due to high alkalinity, low solubility, tissue biocompatibility, excellent compressive strength, high radiopacity, superior than dentines, and here's a fast setting time. So maybe MTA needs about 4 hours for become hard. And usually it's necessary to cover it with temporary material, and next day or maybe on next visit it's possible to place final restoration. So it's necessary to arrange next visit with the patient when we place MTA. Technique of use. So the whole content of one sachet with MTA powder should be used, or one level of this powder, and 1 drop of distilled water, and with spatula this powder with water should be mixed about for 30 seconds to obtain sandy consistency. And this mixture should be applied with sterilized carrier or another instrument into the cavity. And here you have direct pulp capping. So here, contact of the cavity with the pulp chamber. Here, preparation of a cavity. And here on the bottom you place MTA and fill the rest, for example, with GIC. What is important here on the mixture of MTA, we should place wet cotton pellet, because this wetness from inside and also from the cotton pellet create hard material on the bottom of our cavity. And on next visit we can restore finally this cavity. And here covering exposure, pulp exposure after pulpotomy. Here we have larger, more extensive cavity, maybe with some inflammation within the coronal part, this pulp inside the pulp chamber. So we remove the whole pulp from the pulp chamber, but we leave pulp inside the root canals. So this deeper cavity, it is full pulpotomy, because if we remove only some portion of the pulp, so it will be partial pulpotomy. Here it is full pulpotomy. And also we protect here this exposed pulp inside the root canals. We protect with MTA. We place here MTA, also here cotton pellet with, so it is a bit wet, so a bit moisture. And then temporary restoration. On next visit, the patient may have final restoration placed. So here, indirect and direct pulp capping. Please look here. This is a pulp chamber, and it is not damaged here. We have thin layer of dentine. Here, calcium hydroxide material, because it is maybe not hard, not strong enough, so it should be covered with cementum, for example, GIC, and final restoration. Here, exposure of the pulp. So first layer, non-hardening calcium hydroxide material, then hardening calcium hydroxide material, GIC, and final restoration. Or if we have MTA or biodentin, so in case of MTA, so on the next visit it may be covered, for example, with GIC and then final restoration. In case of biodentin, just in a moment I will show you, we don't need to wait for next day because it becomes hard within 12-15 minutes. Here, partial and total pulpotomy. So here, partial pulpotomy. So we remove the pulp here for 1-2 millimeters, and similar behavior. And in case of direct pulp capping, here full pulpotomy, we remove the whole pulp from the pulp chamber, and here we place this odontogenic odontotropic material, the calcium hydroxide, but it may be MTA or biodentin, and here some GIC and composite resin. Okay, next step, if we fail to do it properly, so maybe extraction will be necessary, but we should do our best to avoid it. And here 108, 117 pages from operative dentistry, where you have this direct and indirect pulp capping showed. Just a moment, because it's extensive material. Okay, so you know about this conservative treatment of pulp diseases. Conservative, that means biological treatment. So you know that it is indirect pulp capping, direct pulp capping, partial pulpotomy, and full pulpotomy. So there are these ways of biological treatment. Just a moment. Here on European Society of Endodontology, we have also guidelines for clinicians what to do if you have deep caries. Because I showed you maybe this maybe older recommendations that are present in your books, but there are maybe more updated, because these are recommendations from the previous year, this European Society of Endodontology. So they at first tell about definitions. What is deep caries, extremely deep caries, what is soft, firm, and hard dentin. Deep caries. It is caries reaching the inner quarter of dentin, but with a zone of hard or firm dentin between the caries and the pulp, which is radiographically detectable when located on an interproximal or occlusal surface. There is a risk of pulp exposure during operative treatment. Yes, so deep caries reaching the inner quarter of dentin, but with a zone of hard or firm dentin. What is extremely deep caries? So it is caries penetrating the entire thickness of the dentin, radiographically detectable when located on an interproximal or occlusal surface, and pulp exposure is unavoidable during operative treatment. So in deep caries, we have risk of pulp exposure, but here, if we want to remove all caries tissue, so pulp exposure is then unavoidable. What is soft, firm, and hard dentin? Soft dentin, so it is a dentin that can be excavated with minimum resistance with the use of hand instruments. Firm dentin should be resistant to excavation with the use of hand instruments. And hard dentin should be sound and resistant to probe penetration and scratching. So you know that caries dentin is usually at first is soft, and if you have soft tissue, it should be surely removed. If the dentin is not very soft, but it may be scratched with hand instruments, so it is this firm dentin. But if there is no scratching on the dentin, so it is hard dentin, so it is sound dentin. And now maybe in other terms, selective removal to soft dentin, selective removal to firm dentin, and non-selective caries tissue removal. Selective removal to soft dentin means that we leave that soft dentin is left only on the pulpal part of the cavity, on the pulpal wall, while the peripheral caries dentin is removed to hard dentin. So the surrounding of the bottom is with hard dentin. We have soft dentin only on the bottom, on the pulpal wall. Selective removal to firm dentin. So on the bottom of the cavity, we have firm dentin, but on the side walls, we have hard dentin. Non-selective caries tissue removal. Complete removal of soft and firm caries dentin from the periphery and central aspects of the cavity until hard dentin is reached. So it is non-selective. So it means that we remove dentin until it is hard. And sometimes it may lead to pulp exposure. So what should be done? If we want to maintain the vital pulp inside, so we can perform, for example, selective caries tissue removal in one stage. So it means that we remove to soft or firm dentin, not to hard dentin, but to soft or firm, and we apply a biomaterial onto dentin barrier in indirect one-stage selective caries tissue removal technique. While stepwise excavation, so application of biomaterial in indirect two-stage selective caries tissue removal technique. Temporary restoration placement between visits, and then it's necessary to re-enter the cavity after 6 to 12 months. So it means we have two visits. First stage involves selective caries removal to soft dentin to an extent that facilitates proper placement of a temporary restoration, and the second stage removal to firm dentin. Final placement of a permanent restoration. And here, this direct pulp capping following the preservation of an aseptic working field, application of a biomaterial directly onto the exposed pulp prior to immediate placement of permanent restoration. And so it is not class 1 according to Black. It is maybe an example of direct pulp capping. No, when we had no preoperative presence of deep caries lesion, and pulp exposure judged clinically to be through sound dentin with an expectation that the underlying pulp tissue is healthy. So it is exposure due to traumatic injury to the tooth or an iatrogenic exposure. Another class of direct pulp capping is when preoperatively we have presence of deep or extremely deep caries lesion, and pulp exposure judged clinically to be through a zone of bacterial contamination with an expectation that the underlying pulp tissue is inflamed. So enhanced operative protocol recommended, including aseptic procedure using magnification, disinfectant, and application of hydraulic calcium silicate cement. And here, partial pulpotomy. It is removal of small portion of coronal pulp, full pulpotomy, complete removal of the coronal pulp. And here, because it is pulpotomy, what is pulpectomy? Ectomy, pulpectomy is removal of the whole pulp from the pulp space. So it is both from the pulp chamber and from the root canal system. And here, so pulpectomy, it is this pulp extirpation in local anesthesia that is recommended for irreversible pulp inflammation. Yes, so this last may be conservative treatment regarding maybe this protection barrier in the periapical tissue. So it is this pulpectomy. It is not biological treatment of the pulp because we remove the pulp, but we we don't perform surgical procedures on the alveolar ridge. Yes, so in the course of the procedure, we should perform pulp vitality test, X-ray, anesthesia. We should prepare caries cavity regarding also endodontic excess, isolate with rubber dam, disinfect the operating field, change the instrument into sterile instruments, then rinse the cavity with saline and dry with sterile cotton roll, and then prepare the pulp chamber. Remove the pulp chamber roof, remove the coronal pulp, widen the excesses of the opening excesses, widen the canal orifices. And then we should determine working length. After determination of working length, we should prepare all the canals. So just in a moment, I will show you maybe, but it's 6 p.m. Just a moment here. This just a moment. It's not this here. Yes, preparation of the of premolar. So maybe in quicken. So here you can see entrance into the pulp chamber. We have bleeding. We here locate the root canals with irrigation with sodium hypochlorite. And now canals are visible. And with the use of endodontic file, preparation of the root canals. And here, apex locator is necessary to use to not to work beyond the apical constriction. So here, attaching apex locator, but we don't have here maybe on this movie the apex locator visible. But if we establish working length, so we shouldn't place the instrument deeper than the established working length. Here, finding working length in the second canal. So with this rubber stop, we establish the length. Here, irrigation. And here, use of rotary instruments. Each time we use hand instruments at the beginning, if we don't perform the whole endodontic treatment, if we don't perform the whole endodontic treatment with hand instruments, so they are always necessary to use at the beginning to check the patency of the canal and establishing working length, and preliminary enlargement should be done with hand instruments. And here measuring at aperture before final obturation. Okay, so it is a shortage of endodontic treatment. instrumenting with rotary. Checking at the pattern in next canal. Okay, but because it is okay, it is after 6. Just a moment, I will stop maybe this picture here. Root canal, maybe beginning of the second film, of the second movie. Mandibular molar with cleft root canals. Here, excess opening. Oh, so you can see here entrance into the pulp chamber, but we shouldn't drill only deep. We should at first create a larger entrance. So this excess cavity should be prepared here, because we should have straight access into each canal. In lower molar, mandibular molar, we may expect 2 canals mesially and 1 distally, or 2 distally. And just in a moment you will see entrances into 3 canals here. Oh, sorry, it's just a moment. It's okay to skip. And now checking with the probe orifices of the canals. At first mesio-buccal, then now mesio-lingual, and 1 large distal canal. So you can see the orifice is much larger in distal comparing with these 2 mesial. Yes, so it is pulp tissue, this white string, it is pulp tissue. And here with hand files, this penetration of the canals, checking the patency, working length on the radiograph. Here, small sizes of instruments, and preliminary irrigation with sodium hypochlorite, and initial preparation of the canals. Yes, so these mesial canals are very small. And now GG Gates Glidenberg for preparation of the orifice. Okay, at first size 1, size 2, GG, to enlarge the orifices. Irrigation, drying, and you can see we have much better visibility and access to the canals. And biomechanical preparation, maybe with rotary instruments. Okay, so maybe to show maybe the beginning of these procedures. And just a moment. It was this one. Here, biodentin. Maybe here, biodentin in direct pulp capping. Sorun. Okay. So it's everything.